Assalamualaikum warahmatullahi wabarakatuh to Dr. Adila and Dr. Iswan. So today we are from group 7. We're going to present on molecular and clinical analysis of a neonatal severe hyperparathyroidism case caused by a stop mutation in the calcium sensing receptor extracellular domain, representing in effect a human knockout. Next. My name is Nur Azira Binti Nordin, metric number 202642. So, introduction of neonatal severe hyperparathyroidism. Neonatal severe hyperparathyroidism is a rare disorder caused by inactivating calcium sensing receptor mutation that result in life-threatening hypercalcemia and metabolic bone disease. The mutation on the calcium sensing receptor causes the calcium sensing receptor to lose function and causes elevated parathyroid hormone secretion and hypercalcemia. Next. So based on this diagram, we can see the differences between a normal calcium sensing receptor and the mutated calcium sensing receptor. In the normal condition where the calcium level in the blood is low, the parathyroid gland will secrete the parathyroid hormone, and the parathyroid hormone will help to increase the calcium level in the blood. When the calcium level increases, the calcium will bind to the calcium sensing receptor present in the parathyroid gland sheath cell and inhibit the secretion of parathyroid hormone. Therefore, the calcium and parathyroid hormone are at the same normal level. While in the neonatal severe hyperparathyroidism, the calcium sensing receptor loses function and cannot detect the increased calcium level in the blood. Therefore, more parathyroid hormone are being secreted, causing the level of parathyroid hormone and calcium to be elevated. Next. The cause of neonatal severe hyperparathyroidism start from the parents that have a heterozygous mutation in the calcium sensing receptor and pass it to the children. Then the children that are being born will have homozygous mutation. The calcium sensing receptor mutation will causes the calcium sensing receptor to lose any transmembrane domain that causes knockout. Therefore, produces a loss functioning calcium sensing receptor. Next. So this diagram shows the X-ray image of the infant with the neonatal severe hyperparathyroidism. Radiograph of the patient demonstrating diffuse demineralization, multiple rib fracture, and chondrodystrophy of the distal humerus and femur. And also a butterfly vertebrae was also noted on the chest radiograph. So I'll go pass to the next presenter.
Thank you, Azira. Assalamualaikum and greetings to dearest lecturers. My name is Ain Farisa binti Muhammad Dahari and my metric number is 201065. So what are the symptoms of neonatal severe hyperparathyroidism? As from the research paper that we have found, it says that the symptoms can be present at the first 6 months of life, but can often be discovered in the first few weeks postnatally. Affected infants have severe symptomatic parathyroid hormone-dependent hypercalcemia along with the bony changes of severe hyperparathyroidism. They often exhibit polyuria, which is when someone pees more than normal, dehydration, and hypotonia, which is poor muscle tone and often associated with a history of failure to thrive. Next slide. As for the general symptoms that are not very much stated in the research paper, some of the symptoms are abnormality of the white portion of a long bone, thyroid abnormality, high urine amino acid levels, and also enlarged liver. Now I will pass to the next presenter.
So these are the two cases that are being summarized in our presentation. So let's start with the first case first.
Next slide. Okay. Assalamualaikum to Dr. Adila and Dr. Izwan. My name is Siti Nur Badrina binti Badaruddin and my metric number is 203594. So I will be explaining the chronology of case 1, which happens to a female infant who was born at 36 weeks of gestation. In her neonatal period, she developed symptomatic hypercalcemia, which was treated by intravenous rehydration, oral administration of furosemide, and subsequent feeding of local salt formula milk. Then she was confirmed with neonatal severe hyperparathyroidism when they conduct sequencing on the infant's CAR gene, which shows homozygous mutation, and the parents are heterozygous for the mutation. Next slide. At 2 months old, she undergoes total parathyroidectomy, which results in normal serum PTH and calcium levels and reduced alkaline phosphatase levels. At the age of 8 years old, the patient's biochemical parameters remain normal. And then at 10 years old, she exhibit asymptomatic hypocalcemia, which was treated with 1-hydroxycholecalciferol and calcium-340 for daily. And at the age of 11 years old, she was already a healthy child and grew normally. Next slide. The diagnosis of case 1 is for the physical examination, observe jaundice and poor feeding at the infant, and biochemical examination, observe high serum concentration, homozygous mutation, and also asymptomatic hypocalcemia on the infant. So next, I will be passed to the next presenter.
So, hi, Assalamualaikum. My name is Kamali Sophia binti Baharudin Gumasalam with metric number 203210. Now I will proceed with molecular analysis used to detect NSHPT. First is immunoblotting. This method uses SDS page to detect CAR immunoreactivity. Second is immunofluorescence, where the cells were stained with anti-calnexin antibody as a marker for endoplasmic reticulum, or with anti-TGN46 antibody to stain Golgi apparatus. And the last one is intracellular calcium imaging. The result was obtained after the cells were illuminated through 40 times oil immersion objective, and emitted fluorescence was passed through dichroic mirror and captured with cooled CCD camera. Now I will pass to the next presenter.
Hi, I'm Imzat Fahan Bisharuddin. My metric number is 201023. I will continue to the result of case 1. Result of immunoblotting, temporary transfection of human embryonic kidney to 93 cells with the wild type human calcium sensing receptor exhibit immunoreactivity in transfected cell. R392X mutant cause considerable CAR immunoreactivity in transfected cell, which is 52 kilodaltons. There is no CAR R392X was found in media or transfected HEK293 cells, and after centrifugation, there is no sign of shortened CAR present in patient urine. Next slide. Result of immunofluorescence. Patients extracted parathyroid gland indicate extremely weak extracellular CAR immunostaining when wild type CAR and CAR R392 receptor produced in the cell. The wild type receptor was abundant on the membrane, while the translated mutant has a scattered pattern. CAR localization in cells result is CAR R392X JFP development were mostly intracellular inside the endoplasmic reticulum. Next. Result of intracellular calcium imaging, there is ion calcium mobilization in HEK293 cell transfected with wild type CAR, but ion calcium mobilization was absent in HEK293 cell transfected with CAR R392X in response to ion calcium and MBS R568. Findings show that CAR R92X is non-functional receptor with no carry through the stop codon. Next. This is the result of clinical analysis. The absence of renal CAR activity in patients 8. Calcium preservation. The proben's urine calcium creatinine ratios are poor. 0.16 at age 7 years and 0.22 at age 8 years. This patient has a parathyroidectomy in second month, CT scan at 4 years, and great development intelligence at 11 years old. Neurological impairment which affected this patient is caused by hypercalcemia for a long period of time. Now I will pass to the next presenter.
So this is the chronology for the second case. When the infant was 7 days old, the infant undergoes diagnosis and the infant was proved to suffer from neonatal severe hyperparathyroidism. And the infant have hypercalcemia and hyperthyroidism. At around 10 days old, the infant underwent exploratory surgery of the neck and she developed transient asymptomatic hypocalcemia. And during 2 months old, she developed hyperparathyroidism and hypercalcemia, and the doctor performed thymectomy and the right hemithyroidectomy to the infant. And around 3 months old, no thyroid dysfunction was detected post-surgically and she is free from hypocalcemia. Next. So this is diagnosis of case 2. For physical examination, the infant have a weight loss of 1 kg, hypoactive and dehydrated, no cardiorespiratory problems, and the blood pressure was 85/55 millimole per mercury. And for the biochemical examination, the infant have hypercalcemia, ionized serum calcium, and the serum phosphate was low, while serum alkaline phosphatase activity, serum creatinine, and urea was high. Next, that's all from me.
So my name is Rubina Akira binti Faiza and my matrix number is 202352. So I will continue with the clinical report. This is the molecular analysis where genomic DNA extract from peripheral white blood cells via SNP method. The heteroduplex profile from applicant E41 revealed heterozygosity for an exon 4 mutations in both of the parents. The affected infant was unchanged except for a little shift to the left, which is consistent with homoallelic homozygosity. With PGA transition predicts there are nonsense mutations at position 2 to 7 in the vinous flytrap domain of the extracellular sequence, which is located in the lobe 2. The other heterozygous missense mutations was at R227L and R227W have been reported in table 1. So I will just proceed with clinical analysis after treatment, where hyperparathyroidism of the infant and hypercalcemia, where PTH is equal to 305 nanogram per liter, and hypercalcemia, where 4.0 millimole per liter. After 3 months age, the doctor re-explore the neck of the neck to identify the first parathyroid gland. Unfortunate in the operations, there are no parathyroid gland was found. Thus, thymectomy and right hemithyroidectomy were performed. Histopathology examinations of the right hemithyroid revealed an intrathyroidal parathyroid gland. 3 months after the complete surgery, the skeletal survey found increasing in bone density, which repair of the metaphyseal fracture and the resolutions of subperiosteal absorptions. 2 months after surgery, the patient had asymptomatic hypocalcemia where total calcium was 1.2 millimole per liter and no thyroid dysfunctions was detected post-surgically. So she did not have any hypocalcemia afterwards. I'll pass to the next presenter.
So according to the discussion in both studies, it can be summarized that a novel CAR mutation was expressed in which the protein is truncated in the extracellular domain. Therefore, it cannot exist as a functional or even partially functional CAR. So that's all from me. I will pass to the next presenter.
As for the treatments, there are 2 kinds. The one in the box in the left is the treatments that are done in the hospital, like surgeries and therapies, while the right one is the one that can be obtained over the counter with prescriptions from doctors. As for the left one, the control of hypercalcemia is often obtained through progressive therapeutic intervention involving the use of bisphosphonates, dialysis, and calcimimetics. Bisphosphonates help prevent your bones from losing calcium and other minerals by slowing or stopping the natural processes that dissolve bone tissue. Calcimimetics reduce the serum levels of parathyroid hormone and calcium. If unsuccessful, a total parathyroidectomy is required, which is a surgery to remove parathyroid glands or parathyroid tumors. After parathyroidectomy, lifelong treatment with 1-alpha hydroxylated vitamin D is required. So now moving on to the right box, cinacalcet is a tablet type of treatment. It is a treatment for hypercalcemia in adult patients with primary hyperparathyroidism, for whom parathyroidectomy would be indicated on the basis of serum calcium levels. It is mostly given to patients who are unable to undergo parathyroidectomy, and it increases the CASR affinity for calcium, leading to parathyroid hormone and suppression and increased calcium renal excretion. Now moving on to conclusion.
So in conclusion, neonatal severe hyperparathyroidism is a rare condition characterized by severe hypercalcemia and metabolic bone disease that manifests in the first 6 months of life and more often in the first weeks of life. Although neonatal severe hyperparathyroidism is a rare disease, it should be considered in differential diagnosis of neonatal hypercalcemia as prompt diagnosis and surgical intervention will be life-saving. So that's all from us. Thank you.